Thank you, Mr. Chairman. Good morning, everyone. My talk today is about the role of coronary computed tomography in CTO interventions. So let's define CTO. A CTO is a total occlusion of the coronary artery with a TEMI zero flow in invasive coronary angiography for 3 or more months. In CT coronary angiography, a CTO is defined as a complete absence of contrast opacification within the occluded segment on CT angiography. It's always challenging for radiologists to distinguish between two entities, the CTO and the subtotal occlusion. Usually this happens due to the presence of severe calcifications and sometimes limited spatial resolution in some CT scanners. Also, the presence of linear enhancement in CTO segments sometimes confuses radiologists between a CTO and a subtotal occlusion. We'll go later on and show you what a linear enhancement means. Different predictors in CT angiography for the procedural outcome of a CTO PCI includes the presence of calcifications, stump morphology, the length and presence of multiple occlusions, bending, remodeling, side branches, collaterals, and linear enhancement. So we're going to talk about each one of them separately. The first one is the calcification. The CT angiography is more sensitive than invasive coronary angiography in detecting, measuring, and localizing calcification. And calcification area covering more than 50% of the cross-sectional vessel area is usually the benchmark of presence of severe calcification in CT coronary angiography. If it's difficult to quantify the calcification area, sometimes we depend on the calcification length in relation to the lesion length. If it's more than 0.5, it's used as a predictor of a CTO PCI success. The circular involvement of calcification, whether the arc is like 180 degree more or less, the distribution of the calcium, is it a central calcification or it's a circular wall calcification with a central soft core? So let's take this image for an example. The above images shows an angiography with a CTO of the right coronary. The below image is the CT coronary angiography images. As we can see, I don't know if you have a pointer or I can show you on the images immediately. زي احنا ممكن نتكلم كده اسهل عشان احنا عددنا قليل والقاع صغير. فزي ما احنا شايفين هنا the presence of severe calcification starting from the proximal cap till the distal cap. It's scattered distally, but it's very dense in the proximal segment. If we take a cross-sectional view in the vessel, in the curved MPR, we can see the arc of calcium. Is it a circular involvement? The degree of the arc of calcium, it's like 84.5 degree here. It's almost 120 degree down there. Okay, it's clear. Second, we talk about the stump morphology. The morphology of the CTO cap, the proximal and distal cap, is it tapered or blunt stump? Usually this is visualized in MIP images, maximum intensity projection images in CT angiography. And we, in some studies, found that CT coronary angiography was more sensitive than angiography in detecting blunt stumps because the time required for the CT angiography permits the contrast to stay within the CTO segment within the microchannel segments within the CTO. As we can see, the above images shows a tapered proximal cap, total occlusion segment, and a tapered distal cap. It's a funnel shaped within the curved MPR images, and the lower images shows a blunt proximal cap and a blunt distal cap. The length and multiple occlusions. CT coronary is very sensitive in detecting the length of a total occlusion. As we can see here, the total occlusion in the curved MPR images, like it's 14.5. We can measure it, this one related to this occlusion. And the lower images, we can see there is a long segment of total occlusion almost reaching like 48 millimeters. Bending. CT angiography is very useful in detecting the vessel contour and the course of the vessel, enabling precise measurement of the tortuosity. And it was found that, oh, thank you so much. And it was found that a bend more than 45% in CT coronary angiography was a predictor of a CTO failure. Back to the previous image, we can see here bend at the site of total occlusion in relation to the LAD distally. It was almost like 23 degrees. Down, we found the CTO of the right coronary on MIP images. It shows a blunt cap, a long segment of total occlusion, and a bend almost like 70 degrees. So this is the bend. The angle between the proximal site of total occlusion and the main distal vessel. Okay? Remodeling. Based on CT coronary angiography, the CTO segment remodeling can be classified into a positive remodeling, a negative remodeling, or a collapse. Some studies found that a negative remodeling was associated as the strongest predictor of failed antegrade PCI. This is an image can show remodeling. As we can see, the upper image shows an outward expansion of the vessel wall. It's a positively remodeled plaque in a totally occluded segment. This is the proximal segment, the proximal reference here, and this is the remodeled plaque, as we can see. Okay? The lower images shows a proximal cap, healthy segment, and a negatively remodeled lesion. This is a negatively remodeled lesion. This is a positively remodeled lesion. Linear enhancement. Linear enhancement stands for the microvascular body of the CTO. It appears like a streaks. I'll show it to you. This is an occluded segment, and there is a linear streaks here. This is the linear enhancement. This is what stands for a microchannel in a CTO intervention. So when it's present, it's more successful. It indicates a more successful procedure and better outcome. Presence or absence of collaterals. There are two types, like a septal collaterals or an epicardial collaterals. In this image, we can see an epicardial collateral seen from the right coronary to the distal LAD. And in this image, we can see a septal collateral towards the LAD. This is a septal collateral, and this is an epicardial collateral, and this is like the CT angiography images. So it's very useful to presence or absence of collateral, especially if the spatial resolution of the scanners are improving, so we can see much more collaterals recently. Presence or absence of side branch. The presence of a side branch, a proximal or distal side branch, is defined by the presence of any side branch within a 3 millimeter proximal to the entry or exit of the site of total occlusion. Coronary CT angiography displays the anatomical relation between the side branch and the CTO lesion by various projecting angles. The side branch is a frequent predictor of CTO PCI failure. So according to the previous, what we mentioned previously, there are different CT coronary angiography derived CTO scores, including a CT derived JCTO score compared to the JCTO score in the invasive angiography. And there is a Korean multicenter CTO CT registry score and the CT computed tomography registry of chronic total occlusion revascularization score. If we compare between the three different scores, each one have its own parameters. The JCTO derived score, length, stump morphology, calcification, bending, here also almost the same, except this is the presence of the side branch. Here, the presence of calcification, the area, the stump morphology, presence or absence of multiple occlusions. So these are CT-based scores for CTO intervention, okay? There are other predictors like proximal cam ambiguity, linear enhancement, negative remodeling, presence of collaterals. So, did this impact our practice or did this impact the revascularization success? Yes. According to this study by Hong et al., they found that patients with high JCTO score, which is more likely to be a very difficult CTO intervention, CT angiography was significantly improved the successful revascularization rate, as we can see. But in patients with low JCTO score, which means it's not that difficult CTO, it was not comparable. CT angiography didn't add enough data compared to the angiography guidance. Okay, so there is something new about it? Yes. Nowadays, we can do something called fusion, imaging fusion in the cath lab or co-registration. So you can get your CT coronary angio images, for the CTO segment, and to visualize the proximal cap to facilitate guide wire advancement and reducing the retrograde crossing strategies. You can do a co-registration between the CT. This is the curved MPR. This is a VRT or a volume rendered, and images are registered along with the angiography. So the operator can, during the angiography, visualize this is a totally occluded segment in red, and this is the proximal cap, this is the distal cap. He can adjust the angle and start his intervention, visualizing the ambiguous cap in the better view, visualize the whole length of the course and the tortuosity of the vessel, presence of any bending, any tortuosity, so he can know where he's going, instead of consuming too much contrast. And that's it. Thank you so much.